Dear colleagues, this is a traumatic cataract. This patient sustained blunt trauma in this eye about 1 year ago, and we have taken up this case for surgery. I know that there may be zonular weakness and I may have to place a CTR, so I have kept a CTR ready for this case. Now I want to stain the capsule with trypan blue dye so that I can easily identify the anterior capsular rim. When a CTR has to be placed, identification of the anterior capsular rim will be helpful. So the anterior capsule is stained with trypan blue dye and the dye is washed out. And now in this case, you can see that as we touch the anterior capsule, there is wrinkling of the capsule which indicates a weak zonule. Now viscoelastic substance 2% PMC is injected into the anterior chamber. The pupil has nicely dilated. Now I make 2 stab incisions. This is one on the right side of the main incision and this is another one on the left side of the main incision. The stab incisions in this case are about 3 clock hours away from the main incision. Now the anterior capsule is going to be incised with a 26 gauge bent cystitome. Let us see what happens. As I incise the capsule, you can see that the whole lens moves and there is wrinkling or there is waves on the anterior capsular rim which indicates a weak zonule. So I have to be very gentle in this case. If I pull it sharply, there may be more zonular damage. So I have to pull it very gradually in a very slow motion, and that's it. I am almost completing the capsular axis. Here it is. The axis is completed. Now hydrodissection is to be done. Cortical cleaving hydrodissection. Here it is. Fluid wave is passed just underneath the anterior capsular rim, and we can see that the fluid wave goes from one side to the other side. I did hydro delineation also, which has produced a good golden ring in this case. Now I depress the nucleus and then I try to rotate the nucleus. Let us see if it rotates. Yes, the nucleus is rotating slowly. Now, as the viscoelastic substance is injected again, we are going to use Oatley Cataract 3 phacoemulsion in this case. In case vitrectomy is required, if some vitreous strands come through some zonular dehiscence, this machine will be helpful. It has got pneumatic cutter which gives about 1200 cuts per minute. Now I'm going to do direct chop. I impel into the nucleus, go deep, and then I chop the nucleus into 2 halves. Then I try to emulsify this half, and I notice, which is not visible in this view, I notice that the capsular bag tends to detach from 5 o'clock. So I inject viscoelastic substance and come out. I introduce a cannula, 23 gauge cannula. I ask my assistant to inject visco, and then I come out. Now I am introducing a CTR, a capsular tension ring. The leading haptic has to go underneath the anterior capsular rim. Here it is. Here is the leading haptic. It is engaged underneath the anterior capsular rim, and it goes to the equatorial area, and then I take help of both of my hands and I gradually push the CTR, and when I am near the uh, trailing end, I take a Sinskey hook in my left hand, I take McPherson's in my right hand, go inside, I introduce the Sinskey hook, the prong goes into the eye. Now I transfer the CTR to the Sinskey hook, and the Sinskey hook guides the CTR beautifully to the equatorial region of the back. That's it. The CTR has been nicely placed. Now viscoelastic substance is injected again, and now again I go into the eye with the phaco handpiece. So I am sure the bag will not collapse. The CTR will give enough support, and I will be able to emulsify the fragments. Now, yes, now I am able to emulsify the fragments. Now I rotate the other heminucleus. Here it is. Rotate it a bit and then engage it and chop this heminucleus. Now as I try to get hold of it, I find that the bag is now what I am going to do is I am going behind this fragment and going to engage it from below, and then I am going to emulsify this. And now I must not go to the 5 o'clock. So I try to engage it at 5 o'clock, and I see that there is a lot of stress on the zonule. So I try it here at around 3 o'clock, and I become successful in pulling the epinucleus out of the capsular bag, and slowly I emulsify the epinucleus. And now when I am at the last portion of the epinucleus, I inject the 23 gauge cannula with viscoelastic substance. I hold the needle cannula and I ask my assistant to inject visco behind this last fragment. And now I emulsify this fragment. And when it is shallow again, I inject some more visco. Means my assistant injects visco, I hold the needle cannula, and thus I remove the epinucleus. And as I come out, I ask my assistant to inject visco again. Now I remove the cortical matter with a Simcoe cannula. I go through the side port on the right side of the main incision and remove the subincisional cortical matter. And now the cortical matter which is there at 5 o'clock and 6 o'clock was not coming, so I'm just irrigating. I thought it may get entangled with the CTR. Now once I have done enough irrigation, I try to aspirate this. It comes, but a little bit of it. Here it is. I find that I'm pulling on some vitreous strands. So what I do is, when I realize that I'm pulling some vitreous strands, I go onto the other side, regurgitate, backflush, remove the strand from the port and then come out. Now inject visco again. I am planning to implant the IOL first now. This is the IOL. This is a hydrophobic aspheric intraocular lens. It goes into the capsular bag. Here it is. It goes into the capsular bag, and now I have to aspirate the viscoelastic substance, and I have planned to remove this vitreous strand. When I aspirate this with bimanual IA, most of the cortical matter came out, but this is the vitreous strand which I must not pull. I kept a vitrectomy cutter ready, so I have planned to remove that vitreous strand by trimming it with a vitrectomy cutter. Here it is. I'm trimming that vitreous strand, and I have nicely trimmed that vitreous strand. That's it. So we are towards the end of the surgery. I'm injecting an air bubble before I come out. And now I hydrate the side ports. Why I injected the air bubble? Because I don't want the antechamber to be shallow. And now I remove the air bubble, form the antechamber, and then I come out. Thank you very much for watching. I hope this video will give lot of useful tips that will be helpful in your practice.